Yeah, yeah. So the thing about nutrition, again, it's really basic stuff, which I know is kind of a yawner. But just to kind of refresh some things and some terminology, and again, so we'll fly through this very quickly. So we'll talk about nutrition. One of the big things I would focus on is weight gain and how weight is gained throughout pregnancy. We'll talk about some specific nutrients. We're not going to talk a lot about diabetes today. We're going to hit diabetes more on Friday, which will be pregnancy at risk. And then we'll talk about some, again, interventions to help women have a healthy pregnancy in regards to nutrition. All right, so maternal weight. If you're underweight before pregnancy, you'll notice that you're at risk of these things. So I have kind of the alphabet soup here. SAB is spontaneous abortion, PTL is preterm labor, low birth weight, intrauterine growth restriction, and then birth defects. And again, birth defects is an older term. We're trying to get away from that because there's so much kind of stigma associated with that. Overweight, we can have a long labor, CPD, cephalopelvic disproportion. Cephalopelvic disproportion. And what that means is the baby is too big for mom's pelvis. Remember we talked about the different shapes of pelvises, pelvi, and how most women are gynecoid, and then we talked about the outlet and how you could have a prominent ischial spines and things like that. So again, if you are overweight, we're concerned about you having a bigger baby. Birth trauma, that can be for the baby like a laceration, it could be a fractured clavicle, some type of, again, harm to the baby that occurs at delivery. Fetal macrosomia, again, is a very large baby. If you have a very large baby, that uterus is, again, large and distended, so mom's at greater risk for postpartum hemorrhage because the uterus won't contract down. GDM is gestational diabetes, preeclampsia, and stillbirth. So it's pretty amazing to think, gosh, just being overweight puts me at greater risk for having a baby that might die in utero. And then postpartum, you can have wound infections and thromboembolism. So you can see how we're more likely to see folks kind of in this category than in the underweight category. So healthy people, we want to, again, have women who have a healthy weight prior to pregnancy. There's a movement now to really try and get women to watch their weight gain in pregnancy, but lose the weight within 1 year. We don't want women to lose weight right away, but give them about a year to lose the weight, get back to their pre-pregnancy weight, but also have a year between pregnancy and childbirth, so not have babies right away. When you get pregnant, have a baby, get pregnant again very quickly, it's not kind of giving your body time to recover from that pregnancy, and so you're more at risk when you have those kind of rapid pregnancies back to back. Maternal weight gain caloric intake does not equal nutrient intake. That is important for any patient population. So just because you're getting calories in, it may not be the right kind of calories. And again, we want steady, consistent weight gain. So if you have a patient who's coming in and all of a sudden her weight has moved 7 pounds in 2 weeks, that would be a red flag. Something's not right there. Health conditions, if you have somebody who's having multiples, they're going to have more weight gain than what we talk about. So the parameters I give you are for what's called a singleton pregnancy. A singleton pregnancy means you're only having one baby. And then bariatric clients. I haven't taken care of very many bariatric clients, but the few that I have are very memorable to me. We actually had a patient, she was in the neighborhood of right around 500 pounds when she got pregnant. So it was kind of a miracle that she got pregnant. And she actually lost 150 pounds during her pregnancy. She was hospitalized. She was a very high-risk pregnancy. And it was very difficult. We could not monitor the baby on external monitors. The only way they could monitor the baby was with an ultrasound. And they did a transvaginal ultrasound often because there was just so much adipose tissue here, you couldn't get the ultrasound to be able to see the baby. But basically, she was kind of on a medically supervised nutrition program, and she did deliver early, but overall, she and the baby did well. She was a C-section, so again, there was a lot of complications there pertaining to that. But I do think our bariatric patients, that's again a special patient population, so they really have to be managed with dietitian, endocrinologist, other folks there, so they're a special patient population. The same also would be true for our patients with eating disorders. If you had a history of anorexia or bulimia and now you have pregnancy, you're gonna need some additional support. So again, these are only applicable to kind of general population. With the weight gain in pregnancy, everybody says I'm having a big baby, but you have lots of other things besides the baby that contribute to weight gain, okay? And so when you deliver the baby, you're gonna get rid of kind of the baby, the placenta, and amniotic fluid. So it would not surprise me if somebody comes in, gets admitted, they deliver the baby, and they weigh 10 pounds less on postpartum. They should weigh 10 pounds less because of all the fluid and the baby and the placenta that they've lost. But they're not gonna lose all of their pregnancy weight. Again, it takes time, so you diurese that extra blood volume during postpartum. So you sweat it off, you pee it off, to get rid of the fluid you no longer need because you're not, providing circulation to a baby. But it's this maternal fat stores. And again, women tend to store things kind of up on their hips and their arms, in the abdomen. And that's, again, something that takes time to get rid of after having the baby. Now, this is from the book. I think, again, if you'll notice here, these are BMI numbers. And hopefully those numbers are familiar to you. I would never ask you to calculate BMI, so do not worry about the crazy formula. Because honestly, we just put it in and the EHR tells us what it is. But if I said to you that somebody's BMI was 22, is that okay? Yes. Okay. So if you're normal weight, you're looking at 25 to 35 pound weight gain during pregnancy, okay? Most of our patients in our area and community, and remember, BMI is just one data point, but most of our patients are kind of in this category of overweight. So we look at this 15 to 25. And so let's say you've got a woman who is overweight. If she comes in carrying extra weight, the healthcare provider might say to stay on the lower end, to go more towards the 15 than the 25. Notice you don't see anything up here extravagant. So we really, even if you're underweight, 28 to 40, but that is very, very rare that you see that. So it's, again, this 25 to 35, 15 to 25, but even obese clients will have some weight gain in pregnancy. Now, you need to highlight, you need to put a red pen on this. This is super, super, super important, okay? The amount of weight that you gain should be steady, and in the first trimester, in the first 12 weeks of pregnancy, somewhere between 1 to 4 pounds. And quite honestly, for a lot of our women who are overweight, they may have no weight gain but no weight loss, and that's okay, all right? Now, in the second and third trimesters, it's 2 to 4 pounds a month, which works out to about a half a pound to a pound per week. So now let's apply this information. Give you some practice. So your patient weighed 150 pounds pre-pregnancy. She is 20 weeks pregnant, and today she weighs 162 pounds. Does she have adequate weight gain? Okay, so she's had 12 pounds. She's halfway through her pregnancy. So on the surface, that looks pretty good. What do you think? You don't think so? You think it should be more? Don't know? Should be less. Kind of early to have that much weight. So again, in the first trimester, we're looking at maybe 1 to 4 pounds, which is about the first 12 to 13 weeks. So we've got about 7 weeks. So if she gained about a pound a week plus 4, we're looking at maybe 11 pounds. So it's a little bit on the high end actually for 20 weeks. So again, it's not like we're going to say you need to diet, you need to not, because she's going to continue to gain weight because the baby's growing. But the pace at which she's gaining weight, we might want to slow that down just a little bit. So again, less Snickers bars, candy corn, that kind of stuff. More apples, oranges, carrots, hummus, transitioning what your calories are, okay? So let's practice again. Let's make up something different. We'll say the patient has a BMI of 32. And she has gained 13 pounds at 32 weeks. 13 pounds total. So she said 13-pound weight gain at 32 weeks. What do you think? The lower end, but you think it's okay? You think it's not okay?
Yeah, it's cool.
Would be 21, she's only a little about 20, I think she's on the heavier end.
I think she's on the heavier end.
She's on the lower end.
So in the first trimester, so right around 12 or 13 weeks,
Her BMI's over.
she would have like 1 to 4 pounds weight gain. Okay? And then we're at 32 weeks, so let's make the math easy, which is 20.
So 10 to 20.
But this is half to 1, right, is normal.
Mm-hmm. Yeah.
So I think it's okay. I think it's okay. See how it's not concrete, like you can't say, yep, for sure, there's wiggle room there. But I do think it's this idea of, so when do we see her again?
Maybe 2 weeks.
2 weeks. 2 weeks. And so at this one, if she had no weight gain, I would want to see at least some change there. So again, but I might kind of watch. So what would be another indicator besides weight to tell me the baby's growing okay?
Can I just ask you a question? So I wasn't sure.
Hang tight, let's do this question first. What other data would you look at to help, besides weight, to tell you the baby's growing? Not fetal heart rate, fundal heights. Because remember, maybe her weight is steady here, she's already overweight, but if the fundal height is increasing as it should, that's a good sign that the baby's growing. So what was your question?
So I was thinking, if she had gained 13 pounds in 32 weeks, and she has 8 weeks left to go,
Yes.
so if she gained a pound a week during those next
We're not
weeks.
sure when she's gonna deliver, so if she added 8 pounds, is that,
Yes,
She'd
that's
be
why
at
I said she'd
21
get that
pounds?
heavier end if she went to full term and gained that 1 pound. Maybe she looks good right there, but if she continues, so that's why I would have probably chosen the heavier end on a test is why I'm asking. 'Cause
I think you're pretty close here. I don't think I would change drastically what she's doing, based
Okay.
on this.
Okay, so just kind of.
I would not put her on a restricted diet, but I think you're right, she may be gaining, if she keeps at that same pace. That's also assuming she's gonna get to 40 weeks,
Right,
so,
okay.
okay. Again, the important thing is in the first trimester, the whole 12 weeks, it's 1 to 4 pounds for all of that. And then after you get to that point, it's basically about a half a pound to a pound per week. And it tends to work better for our normal weight people, because our overweight and our obese people, the rules are gonna change. Again, I think if you look back on this slide, see right here, so for example, normal weight 0.8 to 1 over, so they have these funky decimal numbers. I personally do not like the funky decimal numbers. I think you've got enough stuff to keep track of, so that's why I voted with the 0.5 to 1, because I thought that was easier to remember. So that may encompass your person because her BMI's high.
Yeah, I didn't realize you asked it at that time, because at the time she was.
At the time, right. And again, we can't predict, because there's all that kinds of things, but at least right now, you're on target. And I think again, if she asks me and she says, you know, oh gosh, I didn't gain any weight, what data would I use to reassure her? And I would say, oh, well, your fundal height increased, the baby's moving, the fetal heart rate's good, your urine shows us nothing, trace glucose, trace protein, no ketones. Those are all things that tell us everything's going fine in terms of nutrition. All right, so these are super general guidelines. I liked my little graphic because to me, the numbers are just blah. But if I look at this, I can see, so here's the servings of grains, fruits, and vegetables. Some people are not big fans of dairy. They are lactose intolerant. So for example, African Americans may not have a lot of dairy because they can't tolerate lactose. Some people have a lot of gas, so if they're saying they have a lot of gas, you might ask them, they might be really big milk drinkers. The other thing is people have a lot of calcium in their diet, may be anemic, because the calcium actually binds with the iron, so they may need to kind of rein that in a little bit. You have to remember, pregnant women have cravings, and so a lot of times they'll get a lot of a particular food at one time, and so you want to ask about what they're having cravings for. Notice the big jump in protein that you need in pregnancy, so that's real important. In terms of calories though, relatively small amounts, about 300 kilocalories needed in second and third trimesters. So it's not so much, again, the quantity of food needs to change, it's the composition of the food that needs to change. We want to make sure that you're getting essential fatty acids. Remember that a lot of that comes through our protein. So if you have somebody who's low socioeconomic status, they often have lots of carbs. They have rice and pasta, noodles, but they don't get chicken, turkey, fish, nuts, things like that. And then also, in addition to this, you're taking prenatal vitamins as well. All right, so iron deficiency anemia is one of the most common things that we'll see. Remember that it's you may have a physiologic anemia of pregnancy. So we look at your hemoglobin and hematocrit at baseline. We usually repeat that at right around 28 weeks or so. And it's not uncommon for women to need to be on iron at 28 weeks due to this. When you have anemia, you're more likely to have a smaller baby, but you can also see some preterm delivery. It's right in that final trimester that the baby stores iron. So again, it's another reason why it's really important to make sure that we're monitoring mom's hemoglobin and hematocrit. If mom is really low, they might also do some additional lab tests like iron binding capacity and iron storage and things like that. So I bring this up because last spring, folks got really fixated on grapefruit. And I think it was from pharmacology. Okay. And so I totally get the grapefruit thing. I just want to kind of stress, the thing about grapefruit is it impairs metabolism, which increases toxicity of certain drugs, okay? And you know what drugs those. This is a completely different concept. This has to do with vitamin C. We like vitamin C. Vitamin C enhances the absorption of iron. So I just want to make sure and bring that to your attention. When people are taking PO iron, they get GI upset. It makes their poop green and tarry, so it's really important that you tell patients to expect that. The other thing is they will get constipated, so we often will put them on stool softeners. Even if they're already on stool softeners, yes, even if they're already on stool softeners. And yes, this is correct. An empty stomach enhances absorption. So it's best in the most textbook, perfect world to take it on an empty stomach. However, in pregnancy, you often cannot do that because it will make you super sick. So you need to take it with a little bite of food, cracker, piece of toast, something kind of dry. So the book, again, very lengthy in terms of food choices. My guess is you probably know what those food choices are, but this in one slide gives you kind of a nutshell of some suggested foods. This is not all encompassing, but it just kind of gives you, these are really good things to have, particularly in pregnancy. And then notice that there is particular kinds of fish that we would discourage patients from having, and it has to do with mercury. And again, the issue with that is it can cause toxicity and affect fetal development. Vegetarians, you have to remember that for vegetarians, there may be different types of vegetarians. So if you're vegan, no food whatsoever, If you're a lacto-vegetarian, you can have dairy but no eggs. And if you're a lacto-ovo-vegetarian, you can have milk, dairy, and eggs, but, so you wouldn't eat things like turkey and fish and chicken and beef and that sort of thing. My experience with patients in pregnancy who are vegetarian, they are very healthy. Their weight gain often doesn't meet the criteria that we talked about, but their baby grows. And then they often have, again, smooth, healthy pregnancy. Believe it or not, because if they're doing things like nuts and beans and other alternatives, they actually can keep their hemoglobin and hematocrit up as well too. Some women do need supplementation like B12 and iron and calcium. But again, most of the time they're eating healthy and doing pretty well. So vegetarian is fine to be in pregnancy. You don't have any complications with that. All right. So with nausea and vomiting, we usually recommend clear liquids. So things like ginger ale, popsicle, chicken broth, to kind of get you through the initial stage. We want to avoid the triggers for nausea, so certain smells, avoiding those things that make you sick to your stomach. If you have nausea and vomiting and you throw up, but you can eat later in the day, that's pretty normal, that's physiologic, that's expected. If you are not able to eat or drink anything for over 24 to 48 hours, that is not normal. And you have to remember, you'll have other clinical manifestations of dehydration. So for example, your urine output decreases substantially. It gets darker in color. It looks like iced tea. You might start running a fever. Your heart rate goes up. You're lethargic. You have a headache. Yes, you might have dry lips and dry mucous membranes, but to me, the big thing is urine. Like when somebody pees in a cup and I look in their urine, that usually can cue me in if they're getting enough fluids. Okay. We talked about heartburn and constipation. So our sweeteners are artificial sweeteners. One of the big questions is, which artificial sweetener should I use? And the general advice now is it doesn't matter, but in moderation. Okay. So there was all these things about sweet and low, and then there's stuff about equal and aspartame, and you have to remember there's a big kind of very, I think, logical concern about all the chemicals that we're putting into our bodies and how it can affect our growing babies. Another big issue is antibiotics and how antibiotics are in animal feed, and so we have antibiotics in our meat sources and how that's impacting our unborn babies. So I think, again, this idea of very natural kind of whole foods, things that are basic, less processed foods, less fast food. Energy drinks. So energy drinks, the one thing about those, again, they may not be helpful, but they may not hurt. The thing you gotta watch for is the caffeine. Now, caffeine is okay to have in pregnancy, but again, moderation is key. So you don't wanna have a lot of caffeine. Caffeine is a CNS stimulant. Now that said, sometimes what will happen is, mom will ask, is it okay if I have like one soda a day, or if I have 1 cup of coffee a day? I have 1 sweet tea from Callister's a day. Well, that's probably okay. But if you're drinking sweet tea all day long and getting it refilled and having like a quart of sweet tea from Callister's a day, that's something else, okay? Mercury is the big concern for certain types of fish. And again, here in Louisville, oops, I am getting click happy here. There we go. At least to my knowledge, in the Ohio River, we don't have a lot of shark and swordfish. I would not eat fish from the Ohio River. I don't know if you guys have seen the Ohio River, but it's kind of, there's some interesting things that are sometimes found in the Ohio River. So let's talk a little bit about foodborne illness. That is also a really big deal to pregnant women. So it's really important. These are things that can make pregnant women very, very sick. Listeria can come from uncooked luncheon meat. So people who are eating like hot dogs out of their refrigerator and they're not cooking them, which sounds kind of icky to me, but I guess some folks like to do that. Again, if you don't cook your food well enough, you know how some people, they like pink in their steaks when they grill out. Well, that would be discouraged in pregnancy. We talk a lot about salmonella in our fruits and vegetables. So for example, over the summer there was a big salmonella outbreak with cantaloupe. We had E. coli here locally. I live in southern Indiana. Huber's always has a big hoop-de-doo if there's E. coli. You know, E. coli is everywhere, and something you can do really easily to get rid of E. coli is just to wash your fruits and vegetables before you eat them. And again, for some people, it doesn't cause any problem at all, but for some people, it'll make them super sick. So again, just basic behaviors. Don't eat potato salad that's been sitting out all night long. Make sure you don't use the same knife to cut your raw chicken that you're cutting up your broccoli with. And again, basic review from nutrition. With lactose intolerance, again, we do sometimes see that in certain populations. It's important to ask what, again, other food sources you might be able to get what you're looking for. Remember with calcium, we like vitamin D, and vitamin D you get through sunlight. So if you have a patient who's not a big dairy, that's okay. There's certainly other foods that a patient can have to get calcium, vitamin D, and vitamin A. Culture is another big thing, so I think it's important. If you have a patient who's anemic, but you are wanting them to eat meat and chicken, but they're vegetarian or their faith doesn't allow them to eat certain types of foods, then that would be culturally insensitive. You have to remember too that in some cultures, the belief is that the women of the family, they will prepare certain types of foods for the woman to eat during pregnancy to sustain a healthy pregnancy. So they'll bring in this like big giant vat, and it almost looks like oatmeal. It's like gruel kind of, or cream of wheat. And the belief is that, again, the patient will not eat any food that's prepared by someone outside of the family. So they'll only eat food provided to the patient from the family. So it's important to kind of know those things, have good communication, and again, we want to continue to see that the patient, the weight's increasing and the baby's growing and that there's no other complications there. From a socioeconomic status standpoint, we get women connected with community resources like Women, Infant, Children's, SNAP, which is the Supplemental Nutritional Assistance Program. It's not a bad thing. You're doing a great thing to help take care of yourself and have a healthy baby. A lot of people think if I sign up for WIC or if I sign up for SNAP that I have to either breastfeed or I have to formula feed. It doesn't matter. You can breast or bottle feed and be on those programs. Okay. And then I mentioned eating disorders. With eating disorders, one of the things that you might see with this is that women are talking about their weight gain and they perceive it differently. They bring it up a lot or they're hesitant to talk about nutrition. But certainly pregnancy can trigger a lot of those things. It may be something that had resolved several years ago. So you want to make sure you're, again, get the person connected with counseling, mental health. They may need to be seen more frequently to again reassure them that the pregnancy is kind of staying on track, because you have two patients you have to watch, not only mom but baby as well. So pica, I call it pica. Do you want to call it pica? See, to me, pica is something else. It's a journalism thing, which is old. So I call it pica, okay? But I get feedback that I'm saying it wrong. So I call it pica. Pica is where you eat odd things. They are non-nutritive. So it's dirt, it's ice, laundry detergent, flour, chalk dust, ashes from a fireplace, okay? And we see it in people who either had pica as a child, if their family members had pica, so they may have seen that demonstrated with other family members. Sometimes we think it could also be a zinc deficiency, and it's, for women who have pica, they're very reluctant to talk about it. So as the nurse, I'm gonna need to ask the question, so have you had any unusual cravings for things? So just like what your all's response, like, really, dirt, laundry detergent, patients will have that same response. But by asking the question, it kind of opens the door to say, well, you know, I have, it was like the weirdest thing, I just wanted to take a spoonful and just have a spoonful of dirt from the flower pot. Why would I want to do that? And I think, again, it's this idea of it's a craving. And again, it's one thing to have a craving, it's another thing to act upon it.
That's what I was gonna ask, do they actually eat that stuff? Or
Yes, they do. They sure do.
why do they not mentally tell themselves to not eat that?
And I think the idea is that I eat it, it isn't gonna, it's harmless, but some of the things you eat are not harmless. Well, because if all you eat all day is ice, there's not any nutrition in that.
Yeah, I guess I just was thinking like just keep it a little bit.
These are folks, this I mean, so one of the things that cues you into this, these are people who are not meeting their weight goals, the baby's not growing. It's not just an occasional, like, one-time event. It's a recurring behavior. It's significant. And I think, again, the idea is, what can I eat in the place of a spoonful of laundry detergent? Because, again, depending on what you eat, could be poisonous and toxic and cause you to become quite ill. Professor Broderick has a really fun story. She had a patient who got admitted with small bowel obstruction because she was eating tire treads off the side of the road, which I never saw anything that exciting. The most exciting thing I ever saw was the ash from the fireplace. It was just a compulsive, taking, like a little bucket from the fireplace and eating that, so. So what's the problem with pica? Well, obviously it can hurt your baby. It hurts you nutritionally, and so your baby may not grow. And then we can also see patients who end up in surgery because whatever they're eating gets stuck in the gut. And I think, again, the key is we have to present a very non-judgmental approach and just give alternatives to eat instead of that particular item. So for example, with our patient who was eating the ash from the fireplace, we tried to come up with different things in terms of textures and powders and things, but really, once we alleviated other nutritional deficits, it kind of resolved. And I think it was just the shame of admitting that she had done it, and the fact that, again, I think we kind of scared her. It was hurting her baby. And I think that was, you asked kind of what was the motivation. I think that can sometimes work in talking about, well, let's do what's best for your baby, and what's best for your baby is looking at. But if you don't, you have to think about, for a lot of women, they don't have access to adequate nutrition. And so again, they have these kind of uncontrollable cravings, and they're trying to alleviate the cravings. But again, not a very common phenomenon. I don't know recent stats on what percentage of this, but I would say I've only seen it a handful of times. I have seen it in certain cultural groups, and again, it's not just pregnant women who have it, but you can see it in kids as well. All right, so your lab testing. With hemoglobin less than 11 and hematocrit less than 32, that's usually around when we start giving iron supplementation. Women who cannot tolerate PO iron may have to get injections or infusions of iron, depending on how their lab tests demonstrate their iron storage and their iron binding. But in general, you tend to see PO iron supplementation. Serum albumin can be low, and remember, pre-albumin gives us the picture. More recently, serum albumin gives us the longitudinal picture of nutritional intake. And so again, if I have inadequate protein, that's going to be decreased. And then our glucose. So with glucose, we have this value of 70 to 110. It has a lot of wiggle room. So I'm not so fixated on that. So let's say my patient comes in, I do a random blood glucose, and the patient's random blood glucose is 120. I'm not too stressed by that. I'm not calling the doctor about it. I'm not saying she has diabetes, because it's just a random, okay? In general, with patients with blood sugar, I kind of actually want it more on this higher end than the lower end. I get more concerned with pregnancy if I have a patient whose blood sugar is 55. That's hypoglycemic. They get dizzy, lightheaded, shaky, jittery. They can have change in level of consciousness, and then they can't eat anything when they have the change in level of consciousness, so then I have to do other interventions there. But again, I would be more concerned if you had a really, really high glucose, and we're going to talk about gestational diabetes on Friday. So the glucose tolerance test, we wait to do that until right around 28 weeks. And the reason why we wait to do that is because of the hormone that's produced from the placenta. It's the HPL, that human placental lactogen, that works against or antagonizes insulin. And the reason it does that is to make sure enough energy gets to the baby to help the baby grow, because that's a tremendous growth period for the baby. And again, most women, regardless of their history, will screen them at 28 weeks. Now, if a patient's had a history of gestational diabetes and she's pregnant again, she's likely to have it again. And when you have gestational diabetes, that means you're at higher risk of having type 2 diabetes later in life. Okay. Urine, remember with every prenatal visit, we're gonna do a urine dipstick. And when we do a urine dipstick, It's important that you don't take the stick and put it in the urine cup. You take the urine and you pour it over the edge of the stick, because if something's abnormal on the dipstick, you still have a good specimen that you can send off. If you take the dipstick and put it in the urine, you've contaminated, and now your urine is not sterile anymore. So, with the dipstick, we might see a little bit of a trace of protein and a trace of glucose. But if we see more than that, then that would cue us into, for example, you're spilling ketones, you are malnourished, you don't have enough nutritional intake. Also, you might be dehydrated. If you have protein in your urine, that would be a red flag for us for preeclampsia. And if you have glucose in your urine, and again, this would be large amounts, like 1+, 2+, that would make me concerned about diabetes. And so when you're dehydrated, we talked about the physical signs. If I were to assess your vital signs and you're dehydrated, your heart rate might be up and your pulse is low. And remember, in pregnancy, at the beginning, your blood pressure should be right at baseline. So if you normally run, 100 over 60, and you come in and see me in the ER, and you say you've been throwing up the last 3 days, and your blood pressure is 80 over 40 today, and your pulse is 110, that is not normal. You are dehydrated. And a lot of times what happens in the ER is they'll just bolus you with a liter or so of fluids, and usually feel a lot better, and then they may give you some antiemetics. So, if I'm dehydrated, one of the things that, again, gets altered is hematocrit. So the hematocrit, does it go up or does it go down? If I'm dehydrated, it goes up. It goes up if I'm dehydrated, okay? Because hematocrit is what's the percentage of red blood cells made up of the serum, and there's less serum, so that percentage goes up, okay? It's more concentrated. Remember my 2 water bottles, okay? And again, your urine would be very dark,